welcome everyone to the debut session of Cosmetic Corner. This is designed to critically analyze an article in each issue of Aesthetic Surgery Journal. We're going to utilize experts in the field to help us evaluate and really extract the key practice changers from these peer-reviewed works. Tonight, we are fortunate enough to have Dr. Jim Zins as our expert discussant. Among many things, Dr. Zins is the chairman of plastic surgery at Cleveland Clinic and a prominent facelift surgeon. He's the section editor of facial surgery and ASJ, and is also an excellent facial anatomist. We are here to discuss a very interesting article out of Brazil titled Subplatysmal Neck Lift, a retrospective analysis of 504 patients. Overall, this was a very nicely done article with good video content and some novel techniques. I think it's safe to say that the authors in this study were relatively aggressive and meticulous in treating the neck in their patient population. Dr. Zins, thank you for joining us this evening.
Chris, it's a pleasure to be here.
Well, let's go ahead and dive right on in, and we'll talk about three of the techniques that they kind of utilized in this study. First, in the study, about 60% of patients underwent submandibular gland reduction. This seems to be a relatively high number of patients. The authors describe using this 10-20 degree angle marking to determine the level of their partial resection. My first question to you is threefold. Number one, how often do you resect submandibular gland? In your mind, what patients are the best candidates? And then what is your thought on this draw an angle approach to approximate how much gland you do in fact reduce?
Well, Chris, first let me say that these are excellent results that these authors present, and they clearly have a huge experience with over 504 consecutive patients. So this was a very experienced team. With that, however, I would say that a wise person once said that the most complications occur in plastic surgery the week after the annual meeting. So I think that this should be taken into account as we discuss this paper. One, this is complex anatomy, and this is a complicated operation that is technically very challenging. So I think that really should be kept in mind.
Right.
In addition, even in the most practiced hands in this group, the complication rate was relatively high. So as we discuss the submandibular gland resection, I'm going to really echo much of what the authors have stated in the paper, but I think it's important to emphasize several points. First of all, we look at the timing of operation. This operation is not for the faint of heart. This operation took approximately 5 hours to perform on average among the patients.
Right.
Two, the addition of the submandibular gland resection, according to the authors, added 40 minutes to the operation. In my hands, it is actually significantly longer. I would estimate it adds about 45 minutes per side to the operation. So we have to look and see, we have to look at that issue as well.
Right.
Three, the complication rate, even in very practiced hands, was high, with a 4.5% marginal mandibular nerve neuropraxia and a 4.5% fistula.
Right.
From the submandibular gland. So I think that this, again, should be kept into account. And then five, as we read the article, they suggest, as others do, that they need really 3 assistants to do this operation. So I would strongly recommend, one, as the authors do, that this operation not be taken on until you've done a significant number of cadaver dissections. You're very familiar with the 3-dimensional anatomy to avoid nerve injury and injury to the submaxillary gland, and that you start, as the authors have suggested, you start by doing a submental incision and removing fat, trimming digastric muscle, anterior belly and digastric muscle, before going ahead and trying to address the submaxillary gland itself.
Oh, okay.
That being said, I agree with you that 60% incidence of submandibular gland resection is very high. In my hands, I do this about 15% of the time. And you ask about which patients. The patients which are probably most common to do are secondaries who
Right.
present with the unmasked submaxillary gland, and 2, those patients with large fat necks. So those are the patient population which I would address this for.
Now, in that patient population with the heavier neck, when you do resect it, what are you doing are you reclosing capsule, or how are you kind of trying to prevent getting that fistula and those salicyles, that kind of issues there?
There are several ways to do that. I, in addition to other authors, have used the platysma to basically cover that denuded submaxillary gland. So that's one way to do it. Again, obliterating dead space.
Right.
Also, as the authors had intimated, and 2, partially sewing that capsule and the gland together to control bleeding.
Okay.
And then finally, the other point to be made is that a hematoma in this patient population is very different from a hematoma, a standard neck hematoma, because this is really a closed space. Right. And if you get a hematoma in this area, you get bleeding in this area, it really can be disastrous with airway problems. So again, another thing, just another word of caution. A number of very good authors with significant experience will have a trach set by the bedside, and these patients are admitted overnight for observation.
Thank you. That's really helpful. Okay, well, let's move on to another technique that they talk about. They discuss a digastric muscle resection, and most interestingly, the hyoid repositioning with deep hyoid fascia bites. They find this particularly useful in patients with heavier necks. They postulate that this really helps define their cervical angle, and they compare this hyoid repositioning technique to the plication of a diastasis recti and abdominoplasty, for example. I have not seen a lot of discussion of hyoid repositioning and neck lifting. So what are your thoughts on this concept and technique?
Well, Chris, I must say I have not had experience with this technique. The technique that they describe is interesting. They do mention, as other authors do, that these patients will get some difficulty with swallowing postoperatively. So that is something that the patient should be warned about.
Right.
And I think it sounds interesting, but I must say I really don't have any experience with that technique per se.
Gotcha. Okay. What about the hemostatic neck? So they describe this concept where they utilize plication sutures to kind of close down the dead space, and then they remove this net of sutures on post-op day 2. Can you give me thoughts on this technique or process? Or as an adverse, what do you use? Like, do you use tissue glues or certain things to try and get tissue to stick down and prevent hematomas, that kind of thing?
I think that it's a very, very interesting topic, and I think it's a quest that many of us have been on for a number of years, and that is, how do you get that hematoma rate down to 0?
Right.
Interestingly enough, before they were using these so-called quilting sutures or this net, they had a hematoma rate of 9%, which again is rather high.
Right.
So the going from 9% to 0, I think, is certainly significant. So what they're doing, again, is obliterating dead space using techniques that were really developed quilting sutures developed in the abdominoplasty operation.
Right.
The concern, I think, of course, is one, how this looks in the interim, in the first 48 hours, and certainly needs some explaining to the patients. The other thing that I would caution about this, and that is percutaneous sutures through the skin to the SMAS, which is essentially what they're doing, a running percutaneous suture, suturing skin to SMAS to obliterate dead space. Certainly, you have to say it's convincing and effective. On the other hand, in patients in Fitzpatrick 4, 5, and 6 patients, I would be a little bit concerned about the possibility of getting hyper or hypopigmentation.
Right.
So again, perhaps a reasonable thing to do. And I guess my question would be, why not quilting sutures to do the same thing rather than putting sutures percutaneously?
Right. Yeah, and you have to wonder too. I mean, the skin flap viability. Right. We're already raising these skin flaps, and it was interesting. Definitely an interesting concept. Well, to round off the discussion for kind of the residents and the younger aspiring facelift surgeons, I have a couple questions for you.
Sure.
First of all, these authors raised their skin flaps with Metzenbaum scissors. Are you a Gorney, a Metzenbaum, Colorado tip? What's your preferred way to raise your skin flap?
Well, I think, as the authors point out, what you want to do is you want to raise that skin flap in a very regular fashion, So there are those who look directly under the skin flap as they raise them, raising the skin flap relatively thick, but regular. I tend to use iris scissors in the cheek and then Metzenbaum scissors in the neck. Okay. Again, being very careful to keep that regular. I do raise an extended SMAS, and it's very important, probably most important in the cheek, that skin flap is regular in thickness. Again, if you have a thick skin flap, okay, your SMAS is going to be relatively thin. You can't have it both ways. Right. Or you have thin skin flap and a thicker SMAS. Leaving fat on the SMAS, if you are actually doing a SMAS elevation, is extremely important. And it may sound counterintuitive to leave fat. How can fat have strength? But fat does have strength. Yeah. So fat needs to be left on the SMAS if you're going to raise the SMAS as a separate unit. So I think that's certainly important. Again, I think an important point is and a means of reducing your marginal mandibular nerve neuropraxia is instead of using unipolar bovie, you should use a bipolar bovie. And when I went to that many years ago, my incidence of neuropraxia of the marginal mandibular nerve went down to basically to zero. So again, this is also mentioned by the authors, either due to their platysmoplasty or to raising the platysma and doing their submaxillary gland resection. Their incidence of neuropraxia was reasonable. It was about 4.5%, probably a little bit higher because of their approach to the submandibular gland. And
are you tumescing prior to raising your skin flap?
Well, I do Chris. I do a relative tumescence, and then I use 1 to 200,000 epinephrine, a small amount, usually about 30 cc's, and then I use another 50 cc's of 0.25% 1 to 800,000 epi. So it's a relative tumescence, and that's on each side.
And would you say in your practice, how often are you opening the neck anteriorly on your patients, percentage-wise?
Sorry, you cut out.
And you're,
this was actually I was on.
Go ahead. Sorry.
Can you hear me okay?
Yeah.
Okay. I actually was a moderator on a panel at the Aesthetic Society in 2015, and on that panel were 4 prominent facelift surgeons: Jim Stuzen, Bill Little, Sam Hamra, and Tenard. And I asked this very question, the question that you asked me, and I asked each one of them how often they did a subplatysmal dissection through a submental approach. Hamra, 100% of the time. Little, 100% of the time. Susan, 100% of the time. Tenard, 30% of the time. And just to round things off, Zins, 100% of the time.
Perfect. Awesome. Now, the only other complication that gets discussed, but I think is one of those that you really want to watch out for, is in the case where you raise a skin flap too thin and maybe you get a little bit of sloughing. You got this patient postoperatively. If that ever were to happen, what advice would you give, someone in practice as to how to treat that? Do you use nitro paste? Or are you using just antibiotic ointment and Telfa? Or or just, how do you watch and wait? And what's your thoughts on that?
So I think that skin slough it can be related to raising the flap too thin, but I think it's usually tension. Okay, so tension on the skin flap causes bad scars at best and skin slough at worst. So keep tension off, certainly and especially off the neck flap itself, and only mild tension on the cheek flap. If you do develop an incipient ischemic event, it looks like you're going to lose part of the flap. Certainly, you can release sutures. Once it's established, you do not skin graft that. You let that heal by secondary intention, and you'd be surprised at how good things turn out.
Awesome. And then I presume you leave drains. Is that true?
I do use drains. Again, the quilting suture people, they say the quilting suture obviates the need for drains both in abdominoplasty and invasive surgery.
Gotcha. All right, sir. Well, we really appreciate your time. Thank you very much. It's been great to visit with you. So.
Yeah, it's a lot of fun, Chris.
Yes,
all right,
sir.
You take care.
Bye-bye.
Bye.